So in today's class we will discuss about influenza. Now, how many of you have been affected by influenza? Any idea? No. No one got influenza till date. That's strange. Many times you will wake up one day feeling tired, associated with sneezing, sore throat, cough. We call it as flu. Most of the time you will see people calling in sick and stating that they are down with the flu. Now, what is this flu? Let us find out. Looking back at the history of influenza, the probable origins of influenza can be dated back to the times of civilization when human beings became settlers from gatherers and hunters and started living with animals, especially cattle and birds, including poultry. The first noted evidence can be seen in 412 BC by the works done by Hippocrates, where he described the illness similar to influenza. Finally, then by 1357, the first time the term influenza was coined. In Italy, an outbreak of disease was seen in which many people were affected, and it was presumed to be under the influence of cold weather. So the word actually derived from the Italian word la influenza, that means under the influence. Furthermore, the history even suggests the first pandemic, that is, an epidemic that affects many parts of the world, is probably dated back to 1580. Now, let us come back to the modern history. In the modern history, there are many pandemics that had been documented over the years. The first pandemic was seen in 1729. It started from Russia and then spread throughout the Europe. Later on, by 1781, another pandemic of influenza started in China, then spread to Russia and then throughout of the Europe. Furthermore, by 1830-33, another outbreak occurred again from China and then again spreading from Russia, Europe, and even reached up to North America with the advent of civilization and movement of people from one continent to the other. The first devastating pandemic was seen in the year 1889 and it affected Russia predominantly. Hence, it was also called as the Russian flu. Coming back to the 20th century, probably the most devastating pandemic that ever occurred, viral pandemic, was the Spanish flu that affected in the year 1918 to 1919. The disease was initially first identified in Spain. It then spread to Europe and led a devastating outbreak in the North America. As much as one third of the world's population was affected, and about 20 to 50 million people were killed in this pandemic. However, an important part of this pandemic was this was the first time where healthcare officials advocated the use of masks for prevention of the spread of the infection, because please remember at that point of time there were no drugs, no treatment or other preventive measures, and this use of mask is still relevant today. Furthermore, by 1933 the virus was first isolated, and by 1945-46 the first probable vaccine against influenza was also discovered. However, at this point of time the vaccine was mainly restricted to the US veterans, that is the army veterans who were returning from the war. Later on, this vaccine was also used for the general public. By 1952, the WHO first time created a surveillance system for the disease, and the works of the WHO established furthermore for the initiation of production of vaccine at a global scale. By 1957, the pandemics in the Asian region were identified first by the Asian pandemic, first reported in Singapore and then throughout the Asia. Thereafter, the Hong Kong flu in the 1968 to 70 started from Hong Kong and then throughout the Southeast Asia and ultimately spreading across the Europe and the Americas. Now, coming back to the innovations during this period, three important innovations that are notable. First is the year 1963, when the drug called edoxyridine was the first drug that was approved for treatment of influenza. Prior to that, there were no drugs which were approved for treatment. By 1978, the first trivalent vaccine was developed. When we'll discuss about the virus itself, I'll explain why the trivalent is important. And finally, by the year 1993, most effective mRNA vaccine was found to be effective in mice. I think you have already heard about the mRNA vaccine, especially for the COVID-19, which are making headlines today. Those mRNA vaccines were first established in the year 1993. Fast forwarding to the year 2009, we saw the epidemic of what is known as the swine flu. Now, what is this? This is an influenza virus which usually used to affect swines or the pigs. However, it crossed the species barrier and started affecting the human beings. However, one important feature was that this disease was not so detrimental, rather, severe disease was seen only in case of children and adults. And by the year 2019 to 2021, we have seen the pandemic of COVID 19. So, this is the overall history of influenza throughout the ages. Now, let us look at what is the cause of this influenza virus. The virus actually belongs to the group called Myxoviridae. Viridae means virus, Myxo means, any idea why it is called Myxo? Because I'll come to it later. And look at this classification. We have two types of viruses, the DNA viruses and the RNA viruses. Now let us look at the RNA viruses. What are the RNA viruses? We have picoRNA viridae, calciviridae, toga, flavi, boniario, and here comes the orthomyxo and paramyxoviridae. Among the orthomyxoviridae, you can see this is the virus, influenza virus. And among paramyxoviridae, we can see parainfluenza, mumps, measles, and respiratory syncytial virus. As far as the paramyxovirus is concerned, we'll discuss it in a later class. Today, we'll restrict our discussion only to orthomyxoviridae. Okay. So, the influenza virus belongs to Orthomyxoviridae and it is an RNA virus. Now, myxo word derives because these groups of virus bind to the mucin receptors on the surface of RBCs. Hence, they can agglutinate RBCs. This is also called as heme agglutination. If you can see, there is no agglutination over here. On this well, the RBCs have fallen on like a layer. However, in this well, the RBCs have fallen like a group. This is called agglutination. If you go back and read about the immunology classes, antigen antibody reaction, you can find agglutination reaction over there. Now, it would be better if we start to understand the two groups of viruses when we start comparing it. So let us compare. On the left hand side is the paramyxovirus, on the right hand side is the orthomyxoviruses. The orthomyxoviruses, the shape is a spherical shape, and the paramyxoviruses, they have pleomorphic. That means the shape can change. However, the shape remains constant for orthomyxoviruses. Furthermore, if we look at the size of orthomyxovirus about 80 to 120 nanometer, whereas the paramyxovirus is slightly larger, from 100 to 300 nanometer. Now both the viruses will have RNA as their nucleic acid. However, the orthomyxoviruses have a negative sense single-stranded RNA which is segmented. Paramyxoviruses have negative sense single-stranded RNA, but it is unsegmented and only one unit of RNA. And because the orthomyxovirus have segmented pieces, there are 8 segments predominantly. Next difference comes is genetic variation, genetic recombination which leads to antigenic variations. Now, because the orthomyxovirus's RNA are segmented and there are many pieces of the RNA, hence these changes in the genetic order is very frequent in case of orthomyxoviruses. This leads to change in the antigenic structure. That is the reason why in orthomyxoviruses we can find antigenic variations. However, in case of paramyxoviruses, antigenic variations are not seen. Next is the site of RNA replication. For the orthomyxoviruses, the site of replication is the nucleus, whereas in case of paramyxoviruses, it is the cytoplasm. That means orthomyxoviruses will affect the nucleus of the cell in which it has infected. The examples of orthomyxovirus will include influenza viruses, and in case of parainfluenza virus will be parainfluenza, mumps, measles, RSV, and metapneumovirus. Now, please try to recall if you have read or you have heard about, we have effective vaccines for mumps, measles, and if they're given once in the lifetime, they're effective throughout. This is because we do not see antigenic variations. However, you might have heard in case of influenza, vaccination has to be given every year because of the circulating antigenic variants of the strain. Now, among the influenza viruses, we have mainly 3 genera A, B, and C. The structure is a spherical structure on which there is a nucleocapsid surrounded by an envelope, and the envelope is lipoprotein in nature. And this lipid part is derived from the host cells. Now, because it is an enveloped virus with a lipoprotein moiety surrounding it, we can inactivate the virus very easily by using anything which can dissolve the lipid. So, alcoholic hand rubs, hand washing with soap and water is very effective for neutralization of the virus. Why? If this virus loses its envelope, it will not be taken up by the cells. So, if the uptake of in the cells is inhibited, the virus can be neutralized. Furthermore, if you look closely, the viruses have 2 kinds of structures. One is this triangular shaped structure and another is the mushroom shaped structure. Now, what are these? This triangular shaped peplomar, these are called as hemagglutinin. This part will bind to the mucin of the sialic acid receptors on the RBCs, which results in the clumping of the RBCs. This you have understood, they will bind with the RBC. Another important aspect you should remember are the sialic acid receptors. That is, hemagglutinin bind with the sialic acid receptors. These receptors are present in the respiratory epithelium. Hence, this hemagglutinin binds with the receptors of the respiratory epithelium and facilitating the viral entry into the cells. The mushroom-like structure that you can see over here is called neuraminidase. Now, what is the role of neuraminidase? The word ends with this. That means it's an enzyme. So, what is the effect of this enzyme? It facilitates the release of the virus particles from infected cells by passing through the mucin layer to reach the target epithelial cell. That means this will allow the virus to move through the mucin layers of the respiratory epithelium, especially the mucus, thereby facilitating entry into the cells. Have you understood the role of these 2? I have already said the virus has an RNA which contains about 8 segments. Influenza A and B have 8 segments, whereas influenza C has 7 segments. The segment for neuraminidase is absent in case of influenza C. Hence, epidemiologically, influenza C virus infections are comparatively less common. Now, these are the role of each of the 8 segments. You can read. Now, based on the ribonuclear protein and M protein, the influenza virus is categorized into A, B, C, and D. Influenza A virus has the most variations, have 18 H type. H means hemagglutinin type, and 11 N types, that means 11 neuraminidase type. Hence, the viruses are classified based on the type of the hemagglutinin they have and the neuraminidase. Influenza B and C, although they have subtype, have not been designated, whereas influenza D primarily affects cattle and do not infect human beings. So we are mostly restricted to influenza A, B, and C. Having said that, influenza C viruses are less common. Hence, the predominantly human infections are caused by influenza A and B. Now, coming to the standard nomenclature. Because this can affect, we have a standard nomenclature. If you see, first is the influenza type, that is whether influenza A, B, C, or D. The second one is the host. The host is mentioned if the primary host is a non-human. If it is a human, we don't mention the term host. Then the geographic origin, that is the first time from which area of the world the virus was isolated. Then comes the strain number, then year of isolation, and the H and N subtype. For example, look at this strain. Influenza A, then geographic origin is Hong Kong, then the strain number is 03, year of isolation is 1968, and then the subtype is H3N2. Now, if it is a non-human strain, we have to add the host, that is the non-human host, after influenza A. Like influenza A, swine, Iowa is the place where it was found. Strain number 15, year is 1930, and the type or subtype variation is H1N1. So, whenever we are mentioning the type of the virus, we have to mention in this format. Next comes an important topic of discussion, that is the antigenic variations. You have seen in case of influenza A, there are 18 N type, H types and 11 N types. The variations of this lead to outbreaks and epidemics. Let us look at how. So basically, in very short form, antigenic drift means accumulation of small changes in the antigen, that is the genome, which result in change of the protein structure, that is ultimately change in the antigen. Slow changes will result in what is called as drift. However, if there are drastic changes, we call it as antigenic shift. Now, minor changes which occur mainly due to point mutations, these are called as the antigenic shift, and they do have epidemic potentials which will lead to small outbreaks at any geographical location. However, propensity to cause epidemics and pandemics are very low. But if we look at the antigenic shift, like if you see in this diagram, particular virus started affecting the birds or the poultries, then there is a direct jump in the antigenic structure, thereby allowing it to infect human beings directly. So this is a drastic change in the both the ribonuclear protein, which results in the antigenic change in the antigenic structure. This is called as antigenic shift. Now the problem is that drastic changes will result in the population, non-immune population will be affected rapidly, thereby causing epidemics and pandemics. Have you understood? Now let us look at the pathogenesis. Over here, the influenza virus and other the respiratory viruses, they will enter predominantly through the nose and the mouth and will colonize the upper respiratory tract. Now the transmission is mainly via the aerosols. It will start colonizing the upper respiratory tract, and then with the help of the hemagglutinin, which binds with the sialic acid receptors in the upper respiratory tract, colonize there, and then it will come down into the lower respiratory tract where the virus will multiply, replicate, and cause the disease. Now, the spread is very rare. Most of the time, the virus will affect only the respiratory system, and all the symptoms that we can find are all related with the respiratory system. Very rarely it will go systematic to cause systemic infection. However, the local damage in the respiratory epithelial tract may lead to specific changes or complications, very commonly secondary bacterial infections causing pneumonia. Now, how this occurs? Look at over the sialic acid receptor that I've already told you. There are two types of sialic acid receptor. One is the alpha 2,6 sialic acid receptor. This is present abundantly in the upper respiratory tract of the human beings, whereas the alpha 2,3 sialic acid receptors, they are present predominantly in the bird's intestinal epithelium, and it can be also seen few numbers in the lower respiratory tract. Hence, when an avian influenza virus jumps the species barrier and infects the human beings, what will happen? It will cause infection in the lower respiratory tract. When the lower respiratory tracts are affected, ultimately it will interfere with the oxygenation, leading to altered gas exchange at the alveolar level. Now, what is the role of pigs or swine? See, this avian virus have alpha will bind to the alpha 2,3 sialic acid receptors, and the human virus has alpha 2,6 bind to alpha 2,6 sialic acid receptors. The pigs, they have both the type of the sialic acid receptors. Hence, the pigs can be affected by both the avian virus and the human virus. And when a particular organism or an animal gets affected by both the virus, it becomes a mixing pot where both the viruses now, because of the antigenic variations, can bind to both alpha 2,3 and alpha 2,6 receptors. Thus, when this virus will come from the pig to the human beings, it will easily gain access by the alpha 2,6 receptor to the upper respiratory epithelium and also cause disease in the lower respiratory tract epithelium because it also has alpha 2,3 receptors. Have you understood? Now, this is one example. Epidemiological studies have suggested there are various types of influenza virus which can affect very different types of animals, and there is a propensity that any of these viruses can cross the species barrier and cause human infections. So it is hypothesized that in the near future, more and more outbreaks, epidemics, and possible pandemics can be seen by the influenza virus. Now, what is the response of the human body to the virus? The predominant response is by formation of antibodies, that is the human response. And these antibodies against the H hemagglutinin and neuraminidase are protective. How? What is the role of hemagglutinin? It will bind with the sialic acid receptor. So the antibody will neutralize with this receptor, hence the virus cannot gain access into the cells any further. Antibodies against the neuraminidase will decrease the severity of the illness because the disease now cannot spread from one cell to the other. Any other antibodies other than these two are not protective. Only antibodies against these two are protective. Another important aspect is that antibodies against the ribonucleoprotein, they are used to isolate whether the infective strain was influenza A, B or C. However, there is no cross protection from one type of virus to the other. That means if you are affected by influenza A, you will not be protected by influenza B. Another concept is the concept of original antigenic scene. What is this concept? Say you are affected by a particular strain. So what your body will do? Your body will start producing antibody against that strain. Further down the line, you are affected by another strain. Now what will happen? The body will start producing antibodies against the new strain also, but because it has been previously exposed by another strain, it will produce antibodies against the previous strain in a higher amounts. This is called as original antigenic scene. The incubation period of the disease is about 18 to 72 hours, and almost 90% of the people will have what we call as flu-like syndrome, that is uncomplicated influenza. Remember at the start of the lecture I said how many of you have got flu. So generally when we say that a person is having flu or came down with flu, we are referring to this kind of presentation, that is we call as the uncomplicated influenza, where the person will develop minor upper respiratory tract symptoms like chills, mild fever, sneezing, sore throat, irritation of the eyes, anorexia, and myalgia. It is generally a self-limiting condition. However, in some patients, we can see what is called as secondary bacterial pneumonia. Now, why this happens? Because the influenza virus will interfere with the normal functioning of the respiratory epithelium, thereby decreasing the local immunity. And when the local innate immunity is decreased, the person is more susceptible for bacterial infections. It is seen that Staphylococci, pneumococci, and Haemophilus influenzae B are the common causes of secondary bacterial pneumonia. This is all about for the normal human beings. However, patients with COPD, cardiovascular diseases, they are more prone to severity because infection with influenza will ultimately result in altered gas exchange at the alveolar level. If any other wing, either the respiratory or the cardiovascular wing is compromised, these patients will have even more severe complex. Another problem is seen in children, what is called as the Rise syndrome. So, who are the people at risk? Children less than 2 years, people more than 65 years, pregnant women, people with chronic diseases like COPD, chronic renal disease, and hepatic disease, and people with low immunity like HIV infected, or people undergoing chemotherapy for any treatment for malignancies. Another important epidemiological feature we can see is the seasonality of influenza. In the Indian subcontinent, influenza infection is very commonly seen in the winters. And today the incidence is about 3 to 5 million cases of severe illness and attributes to about 2.5 to 5 lakhs deaths worldwide. Now, we'll look at two important strains. First is the avian flu. Have you heard about the bird flu? The bird flu infection that was seen is caused by the avian flu. The birds are the primary receptors. However, important aspect is that this highly virulent strain possesses the PB1F2 protein, which targets the host cell mitochondria and causes apoptosis. Now, this virus, when it crossed the species barrier, started causing human infections, and this was called as the H5N1. Other than this causes a pandemic. Other than this, there are many types of avian flu, which includes the H7N7, the Netherlands strain, or the H9N2 Hong Kong, or H7N9, which was seen in China. Among the most important human infections are caused by H1N1. Now, this, after the pandemic of 2009, has been circulating worldwide, and most of the time the seasonal influenza is caused by this strain of H1N1. So, if we are suspecting any person who is a probable person who is infected with influenza, the first suspicion will always be H1N1 as of today. It generally affects during the winter season, that is the December, January. Uncomplicated influenza is seen. However, high risk people will have complicated infections. The Integrated Disease Surveillance Program in India under the National Center for Control of Diseases has a surveillance program monitoring the cases of H1N1. Hence, all these cases has to be reported. The guideline by the Ministry of the Health and Family Welfare have categorized the patients into three categories. First is category A, in which we have the typical flu-like illness, and the guidelines recommends that the patient might not be tested and the patient can be given symptomatic management and treated at home. Category B includes people who are at a higher risk of complications having flu-like illness. And what the guidelines said, that although laboratory diagnosis is not required, however, symptomatic treatment along with anti-influenza therapy by oseltamivir can be given. This is for the category B. Now, category C includes people of the category B in whom we can see breathlessness, chest pain, fall in blood pressure. That means patients have developed complications. For those patients, we need laboratory testing, and these patients has to be managed in hospital. You cannot ask them to go home. Okay. So if you look at it again, this category is very simple. The first category is the apparently healthy people who have flu-like illness. You don't need to test them, give them symptomatic treatment, and ask them to take rest at home. If the same kind of presentation is seen in people in whom complications may arise, you don't need to test, send the patient back home along with symptomatic management, give them antiviral or anti-influenza therapy with oseltamivir. However, if any of these patients develop complications, predominantly with respiratory or cardiovascular complications, you have to test these patients, admit the patient in the hospital, and obviously you have to give anti-influenza therapy. Now, the IDSP does the surveillance for influenza in India. Globally, WHO's Global Influenza Surveillance and Response System surveys for all the influenza infections that is seen worldwide. Now, coming to the laboratory diagnosis, the best sample would be what is initially the infection occurs at first. It occurs in the upper respiratory tract. Hence, the best sample would be a nasopharyngeal swab or a laboratory or a nasal aspirate. A poorer sample would be a throat swab. Best sample would be a Dacron swab. Why? Dacron swab lets the isolation of the virus much better than a cotton swab. Hence, it is preferred the Dacron or rayon swab can be used. Furthermore, these swabs has to be kept at 4 degrees centigrade and then transported. And if it not tested, it has to be kept at minus 70 degrees centigrade. Why? Because we are looking for a virus, and this virus is a temperature sensitive virus. Initially, the isolation of the virus was done on either embryonated eggs or cell line culture like primary monkey kidney cells. After the growth of the virus, we can test for both hemagglutination and heme adsorption. However, this is not done now because it is not only laborious but is also not cost effective. Other alternative means of diagnosis is called as the direct immunofluorescence test, in which viral antigens coated on the epithelial cells can be seen directly under the fluorescent microscope. However, the problem with this test is that this is much less sensitive. If it is positive, then it's fine, but if it's negative, it does not guarantee that infection is not there. Best modality of diagnosis as of today is called as RT-PCR or reverse transcriptase PCR. Why reverse transcriptase PCR? Because the virus contains RNA. So we need to change the RNA into DNA and then undergo PCR. This is called as the reverse transcriptase PCR. Advantage of this test is that we can get the results within 1 day, and it is highly specific and sensitive. So the standard diagnostic modality as of today is RT-PCR. Other than that, we can also look for the antibody detection by using hemagglutination inhibition, neutralization, or ELISA. But then with the serological testing, the antibodies will come after 5 to 7 days. Coming back to the treatment, I have already told you oseltamivir can be used. What is oseltamivir? This is a neuraminidase inhibitor along with zanamivir. This can be given twice a day for 5 days, and oseltamivir can also be used for chemoprophylaxis. Other than the neuraminidase inhibitor, we can also use matrix protein M2 inhibitors like amantadine and rimantadine. So when you will be studying about the antiviral drugs in your pharmacology, please go through all these drugs. Antiviral treatment is on one side. The main aim of our management, if we are suspecting influenza outbreak, is to prevention of this disease to become outbreak or an outbreak into an epidemic. The main role of prevention is by preventive measures that we have to take. What are the preventive measures? First is strict hand hygiene. Why? Because the predominant symptom that is seen in influenza is rhinitis, sneezing, and coughing. In all these activities, the hands of the affected people will have the virus. Now, please recall that the virus has a lipoprotein envelope which can be easily, and hence the virus can be easily neutralized if we are using hand hygiene techniques, either hand rub with an alcoholic base or hand washing with soap and water. Next is we need to isolate the patient and do not allow him to mix with the other people. Hence, if we are suspecting that the person is affected with influenza, we have to isolate the patient. So we have to give that person work leave. If the person works, suppose in this room, if anybody have influenza, what will happen? Almost technically everyone will be infected. So the best management would be to isolate the person. If the person is not severely affected, we can isolate at home. And if the person is severely affected, we have to isolate the patient in the hospital. Next is respiratory hygiene. What is respiratory hygiene? Any idea? It is called as respiratory hygiene and cough etiquette. You would have seen many pamphlets in which people or the common people are being taught how to cough, how to sneeze. And another important part is the use of masks. Over the last more than 100 years, it is still the most effective method of prevention of spread of the infection. Then work restriction and vaccination. Work restriction, I have already told you, if any worker is affected, you have to grant him leave. Finally is vaccination. The problem with vaccination is that because of the antigenic variation, every year there is change in the strain. Hence, if you are vaccinated this year, there is a high probability that that vaccine will be ineffective next year. So people who are either more susceptible to severe infections because of comorbidities or other medical conditions, or people who have a higher probability of getting infected like healthcare worker, nursing personnel, they have to be vaccinated almost every year. Understood? So how these vaccines are being given? WHO recommends the probable change of the strain beforehand. Based on that, the vaccine is designed and prophylactically that vaccine is given worldwide. There are two types of vaccines, both injectable and live vaccines are seen. Injectable vaccines are obviously they are not live vaccines, and the live vaccines can be given by the nasal route. So these are a different modified type of vaccine, the live vaccine, in which the virus is designed so that it can survive at a lower temperature, about 33 to 34 degrees centigrade. Hence, it can survive in the upper respiratory tract, but it cannot survive at a higher temperature, about 37 degrees centigrade, which is seen in the lower respiratory tract. Hence, these live vaccines will cause the infection in the upper respiratory tract, but will not cause the disease in the lower respiratory tract. So finally, coming to chemoprophylaxis, the chemoprophylaxis can be given in the post-exposure situation, especially during the outbreak seasons in the hospital. Chemoprophylaxis is given very commonly by oseltamivir, or commonly known as the Tamiflu, and the indication is if the person is not vaccinated or have been vaccinated recently. That means it is not estimated that the patient will mount a immune reaction to the vaccine, or the people who are immunologically compromised like HIV infected people. These people have to be given the vaccine. Please remember, if the person is immunologically compromised, we have to give injectable vaccines or the kill vaccines. Live vaccines are not preferred in these people. And finally, during the outbreaks, a minimum duration of 2 weeks continuing up to 1 week after the last case was identified. That is the duration of the chemoprophylaxis that has to be given. Okay. So this was all about influenza. Any questions? Thank you.